good afternoon and good evening to our distinguished speakers, chairs, and audiences of the ACNS webinars in different parts of the world. Today is the 9th session of our anniversary edition of webinars, and as usual, we have two great speakers who are going to enlighten us through that very insightful lectures. The speaker for the first session of today is a world-renowned faculty and is considered one of the doyens in spine surgery, Professor Edward Benzel. Professor Benzel is the Emeritus Chairman and Director of Career Development for the Cleveland Clinic Neurological Institute, assisting the Institute and neurosurgery chairs in their ongoing quest for excellence in all domains, including clinical, education, and research. In these capacities, he has assumed an overarching mentorship and guidance role while maintaining a busy clinical practice that focuses on complex cervical spine pathologies and spinal cord tumors. Dr. Benzel's major clinical research interests have embraced many aspects of neurosurgery, but have focused on spinal disorders. He has published 310 peer-reviewed manuscripts, 420 book chapters, and over 600 abstracts and commentaries, and he has edited 28 books. Dr. Benzel's single-authored first, second, and third edition textbook entitled Biomechanics of Spine Stabilization has revolutionized the surgical management of spinal disorders. In addition, the first, second, third, and fourth editions of Benzel's Spine Surgery Technique, Complication, Avoidance, and Management are highlights of his publication endeavors. His works as a contributor to literature is not done, and he continues to publish, and in 2015, he became the editor-in-chief of the World Neurosurgery. Dr. Benzel is actively involved in AANS, CNS, ANS-CNS Spine Section, the Cervical Spine Research Society, and the Lumbar Spine Research Society. He has played a seminal role in both the development and delivery of hands-on spine surgery courses since the early 90s. We are extremely honored to have him today as a speaker for our webinars, and today is going to talk about total disc arthroplasty, hope or hype. The speaker for the second session of today is our very honored faculty from USA, Professor Aziz Sultan. Professor Sultan is the Chief of Division of Vascular and Endovascular Neurosurgery in Department of Neurosurgery and is the co-director of the Comprehensive Stroke Center and an Associate Professor of Neurosurgery at the Harvard Medical School. At the onset, I would like to congratulate Professor Sultan on behalf of the ACNS for being awarded the Distinguished Clinician Award 2021 from the Brigham's Health. He is a lead researcher engaged in various trials about cerebrovascular neurosurgery. He is working on novel projects, including application of biomarkers and stem cells in the diagnosis and treatment of stroke. He has also collaborated with the Brigham's and Women's Neuro-Oncology Group to utilize cerebrovascular imaging, access, and drug delivery for brain tumors. He has been a mentor to several neurosurgery residents and an active proponent of global neurosurgery. We are extremely honored to have him today as a speaker for our webinars, and today he is going to talk about utilizing stroke and digital technologies to remap access to care. The chair for the first session of today is a very well-known giant and an icon in the field of spine surgery in China. It is my great honor to introduce to Professor Feng Zinjian. Professor Jian is the Vice Chairman, Department of Neurosurgery and Director of Neurospine Center, Suanu Hospital, Capital Medical University, China International Neuroscience Institute, Beijing. He was the President of the Spine Committee of the Chinese Association of Neurological Surgeons till 2017. He was the Executive Committee member of the Asia Pacific Cervical Spine Society and the AO Spine China. He was also the AO Spine China Education Officer till 2020. He is a noted author with several publications in various leading journals. We are extremely thankful to Professor Feng Zinjian for accepting an invitation to chair the first session of our webinars. The chair for the second session of today is Professor Timo Krings. Professor Krings is the Professor of Radiology and Surgery and the Chief of Radiology at the Toronto Western Hospital and the Head of Division of Diagnostic and Intervention Neuroradiology at the University Health Network, Mount Sinai Women's College Hospitals. He holds the David Braley and Nancy Gordon Chair in Intervention Neuroradiology at the University of Toronto. Focusing his research efforts on imaging and treatment neurovascular diseases, Dr. Krings has published more than 420 peer-reviewed articles and approximately 30 book chapters and 4 books on spinal, pediatric, and intervention neuroradiology and neurovascular anatomy. Dr. King's leadership in the field of neuroradiology is bolstered by his distinguished grants and awards, including the Scientific Award for the European Society of Neuroradiology, the Lucian Apple Prize, and the Founders Award in Intervention Neuroradiology of ESNR. We are so grateful to Professor Krings for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, as well as the audiences to this online platform of ACNS webinars. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual platform to Professor Feng Zinjian.
Okay, thank you, Raja, for the introduction. So now it's a great honor to have Professor Benzel for the, I think we all know him very well. Professor Benzel is a real world-class master, but he's also a mentor. and today he will present to us about the artificial disc on cervical spine. As we all know, since its birth, the artificial disc is always the subject of debate. It's good honor to have Professor Benzo, which he will give us his advice today. So please, Professor Benzo.
Hello, everybody. Thank you for the very kind words. I'm not sure I'm deserving of any of that, but I'll take it. I'm going to talk about motion preservation and with a prelude of a discussion on biomechanics. And I have a bias, and I imagine many of you don't use motion preservation devices. Some of you may. And I am simply going to point out what I understand to be the fundamentals and the biomechanics of several devices that are commonly used today. I'd like to start off with a brief discussion of biomechanics. Bending moment equals force times distance. So a force F applied at a distance d from the axis of rotation causes a bending moment, which is the product of the force times the distance, which initiates a concentration of stress ventrally, and failure begins and then is propagated dorsally. With spinal instrumentation, we tend to reverse this process. And it's all about leverage. Archimedes said, "Give me a lever long enough and a fulcrum on which to place it, and I shall move the world." We tend to think in terms, and appropriately so, in terms of the Cartesian coordinate system, where there are motions along and around each of the three axes. Again, this is our cartoon of choice here. Force times distance creates a bending moment and a concentration of stresses. There are many ways that we can resist deformation. We can distract. We can apply three-point bending, which requires at least 3 points of fixation, as depicted by this man on a springboard. We can compress, and we can employ cantilevers. A cantilever is a beam that is affixed to an immobile object at one end only. If it is rigidly affixed, we call it a fixed moment arm cantilever beam. If it is affixed by something like a hinge or a screw that can toggle, we'll call it a non-fixed moment arm cantilever beam. And then, of course, we can apply bending moments. The most common way we do that is with cast bar pins, for example, with anterior cervical spine surgery. Often implants, whether they be motion preservation devices or other implants, can fail by subsidence. If we push in the middle of a tin can, it bends in. If we push on the edge, it doesn't. So the vertebral body is the same. The perimeter of the vertebral body or a can bear axial loads much more effectively than the center. So we should put devices like total disc arthroplasties that encompass the entire surface of the end plate, or if we're putting in bone grafts or spacers, putting them more towards the periphery as opposed to the middle of the disc interspace and end plate would be most appropriate. Implants fracture. This implant fractured near the tip and the previous one near the base. Implants always fracture at the point of maximum stress application. So let's talk about zeta, which is strength. It is proportional to the third power of a rod or the inner diameter of a screw. And stress is bending moment over strength. Again, when an implant fractures, it always fractures at the point of maximum stress application. Here is a fracture. Obviously, the cross-sectional area of the implant is not very great here, and a bending moment was relatively long, which caused a fracture at the point of maximum stress application. This fractures at the base, and this one fractured near the tip. Why is that so? Well, let's look at the fixed inner diameter screw that fractures at the base. If we apply a force to this screw, the bending moment increases gradually and is maximum at the base or at the plate. And the strength of the screw, which is related to the third power of the diameter, is the same all the way across the screw. So the actual stress will be maximum at the base and the screw will fracture there. What about a tapered inner diameter screw? Well, the bending moment still rises and is maximum here, but the denominator of the stress equation increases exponentially because it is proportional to the third power of the inner diameter of the screw. So as we pass along the screw, the stresses actually diminish, and where they are maximum is near the tip of the screw, which is why that screw fractured there. Screws that toggle can windshield wiper and cause a degradation of the screw bone interface, but they are dynamic and they allow bone grafts and cages, et cetera, to see bone healing enhancing compression forces. This is an interesting case of a patient who was treated by an early generation cast bar plate with slots on one side, screws on the other, slots, holes, slots. So the screws that were in slots held the position and allowed the implant to subside, whereas screws that were in holes fractured or backed out as the implant subsided. Interestingly, this patient went on to a fusion, partly because the bone was able to see the compression, bone healing enhancing forces. Here's another example of a fracture of a toggling screw or a non-fixed moment arm cantilever beam screw. Implants function different under differing loading conditions, and we must be cognizant of this with all implants, including and maybe specifically motion preservation devices. Is there such a thing, I ask, as a ventral compression implant? And there is, but you probably can't think of one at this point in time. Let's think of this. We know we can compress from behind, like with a clamp or a cerclage wire, but can we compress from the front? Here's a wire going around the spinous processes that provides posterior compression. But let's look at this plate. It's a fixed moment arm cantilever beam. If it's placed in the vertebral body, it acts in resisting compression. So it's a distraction device. It's also a cantilever beam, as I mentioned. And if we were to insert this and the patient were to extend his or her neck, it would resist compression. Resist extension. So it is therefore a compression device. So this device functions differently under differing conditions. And if we do not understand that, we will have problems with failure of our implants. And then finally, the modes that we can use to resist deformation include distraction, tension band, fixation, three-point bending, and cantilevers. This construct is known to be associated with a high degree of failure. It's called a bridging implant with a long strut and screws only at the top and the bottom. It's a cantilever beam. It's a compression device. It's a distraction device. What it is not is a 3-point bending device. It is missing an intermediate point of fixation. So it doesn't fail because it's not good at axial loading. In fact, it fails because the implant shifts and moves and rotates, and screw bone interfaces can be degraded. Simply creating an intermediate point of fixation can cause the entire implant to move in unison. So here's what we see if we you employ this implant in a relatively large fraction of the patients. So putting an intermediate point of fixation can help stabilize the spine and cause all the implant components to move in unison and together. Of course, we could put a anterior with a strut, anterior bridging implant with a strut, and a posterior multi-segmental implant, which would accomplish the same biomechanical goals, but it wouldn't allow us to correct deformity, and it's 2 operations, and many of the patients that we operate on with these problems are fragile and infirm, and 2 operations may not be in their best interest. Now, this is a diagram of the stress strain curve. If we look at the white curve here, the line from A to B is the neutral zone. I would like you to think of the neutral zone as the zone of non-engagement. If I push on my finger as I am depicting here, it takes very little force to cause significant motion. But once I get to B, and I'm meaning resistance, so now it requires much greater force to create deformation. This is the elastic zone. The slope of the curve in the elastic zone is basically demonstrates the stiffness of a device. Then once we get up to here, we start seeing plastic deformation and then ultimate failure. So if we have a patient with mechanical back pain, and I'll talk about that in a bit, the biomechanical correlate of that is a widening of the neutral zone. The spine has become a little bit more sloppy or loose when motion is occurring. And that patient may benefit from a procedure which reduces the size of the neutral zone or eliminates the neutral zone. So I'd like to outline the definition of a syndrome. A syndrome is a group of identifying signs and symptoms, a group of signs and symptoms that together are characteristic or indicative of a specific disease or other disorder. Mechanical back pain is, or mechanical pain is a type of pain which can be surgically treated. Total hip arthroplasties can be used to treat mechanical pain in a degenerated hip or knee. The syndrome is relatively classical, whether it be a hip or the spine. The pain is deep and agonizing in nature. It is worsened with loading and improved with unloading. If the patient doesn't exhibit all 3 of these, beware of a surgical procedure helping them with their pain. They should have the deep and agonizing pain. It should get worse with walking, loading, bending, stooping, but it should be improved with unloading. In other words, the patient should be able to seek and find a position of relative comfort. If they cannot, it is very unlikely that we're going to be able to provide that for them with any surgical procedure we perform. I'm going to briefly discuss 3 forms of types of motion preservation devices and other motion preservation techniques, and then focus on total disc arthroplasty at the end. Interspinous spacers preserve motion by creating a little bit of a stiffness between the spinous processes of two adjacent vertebrae. Now, proponents of this technique say that it doesn't really cause much flexion, but the problem is it does. It may not cause flexion, but it eliminates extension, which is the harbinger of many of spine deformities as we age. So it's basically promoting this pathological posture that we see in this gentleman with almost certain lumbar stenosis symptoms. So with regard to interspinous spacers, my opinion, and keep in mind, it's my opinion, it's that it's not hope, it's all hype. That's my opinion. Dynamic spine stabilization involves putting in screws into bone and then some into the vertebrae through the pedicle usually, and then having some sort of a buffer or a stiffening device, but not a rigid rod in between. Perhaps the most common used up to date is the Dynasys system depicted here, where there is a cord through the middle and a plastic-like tube that is bendable. So ideally, a device like that should neutralize the neutral zone. In other words, shift this stress-strain curve from the right to the left. But there have been a number of studies, including this one by Dieter Grob from Zurich, that demonstrate that it did not improve back pain in patients with mechanical back pain. Now, part of that may be related to the way it is inserted. If you read their instruction manual, they say that you put this device in between the two screws that you're going to connect and squeeze until you can get a measurement, and until you basically, the surgeon is squeezing until it feels good. I don't exactly know what feeling good means and how much you should distract. And by the way, as you distract the heads of these screws, you're actually putting the patient into more of a kyphotic posture. So perhaps dynamic stabilization devices, as we proceed into the future, may find a resurgence as we develop techniques that minimize kyphosis, minimize shifting of the axis of rotation, etc. Now, I'm going to spend the majority of the time remaining now on total disc arthroplasty. But by the way, let me go back here. Hope versus hype for dynamic stabilization, I don't know. I will call that to be determined. And I'm also going to call it to be determined for total disc arthroplasty as well. I simply am here today to cause us to think about what we're doing when we do or consider a total disc arthroplasty operation. There are two distinct categories here of total disc arthroplasties, and they are lumbar versus cervical. In lumbar, we're treating mechanical back pain. In the cervical spine, the total disc arthroplasty is essentially a spacer that is used after an anterior cervical discectomy. It replaces a plate and a cage or allograft bone. Lumbar, as I said, is for pain. And if it is used for such, it should be used for mechanical back pain, the syndrome, mechanical back pain, pain that is deep and agonizing in nature, worsened by loading, and improved by unloading. So this is a first generation Charité disc that is about 20 years old. And this patient has enjoyed significant benefit from this procedure. This type of device is no longer used, and the Charité has advanced their technology quite a bit. So in this N of 1, the results were very good. So oftentimes I will be asked the question, well, what is the pain generator? I don't know what a pain generator is. So you're going to not get a good answer from me on that. The mechanism of pain in the mechanical back pain patient is a widened neutral zone or extended neutral zone. And in fact, it's related, the pain is related to excessive and or abnormal motion of the disc interspace, just like with a mechanical, just like the mechanical pain that is associated with hip degeneration. Discogenic back pain even goes back further, or even makes me scratch my head even more. I think it's circular thinking to think that there is discogenic pain, which causes the patient to have significant symptoms. People have looked at things like high intensity zones in the disc itself and the potential cause for back pain. I personally don't understand that. And I will go back to the one syndrome that we can effectively treat with a spine operation is mechanical back pain, deep and agonizing pain that is worsened with loading and improved with unloading. So if we look in youth, our discs are gelatinous. They tend to then become more consistent like rubber, and then become desiccated in mid to later life, and then ultimately they could become fused. And if we look at the pressure within the disc of a youthful spine and look at the pressure across the radius of the disc, we see that it's low at the top and the bottom, or front and back, and it's high, consistently high in the middle. These were done in volunteers who were standing. Middle-aged people, we tended to see a rise of the pressure towards the perimeter of the disc and a fall off in pressure towards the middle of the disc, and then a rise again at the end. And in the very aged spine, where there is significant degeneration and desiccation, we see a significant drop off. And just as a point of reference, if this pressure goes below 0, we will see what appears to be air in the disc interspace, or what we call the vacuum phenomenon. So when we're talking about total disc arthroplasties, we need to discuss motion and loading, and we need to not just think of it as one entity, but in which plane, axial, translational, or bending, and along which axis with rotation, coronal, axial, sagittal. So again, we must be thinking of this stress-strain curve and whether we want to replicate normal or whether we want to create a fusion. It should be paramount in our mind as we think through a strategy to care for the patient. Let's look at the flexion and extension motion of a variety of motion preservation and fusion devices. We have the Charité disc, just as an example. It's metal on poly, so it's very hard surfaces. This is a Acroflex disc that Art Steffi invented decades ago, and it actually worked, but had problems with delamination of rubber from the metal. But it's sort of a rubber disc. And then this is the Degeneration system, and then this is a fusion. So let's look what happens in the Charité disc. It's a ball and socket joint. So whereas we're trying to replicate the normal ABC stress strain curve, we actually create this situation where there's essentially no resistance to flexion extension or lateral bending. This device probably does not have a neutral zone or an elastic zone, but a combined neutral and elastic zone. And so it makes some sense. Now, I've already mentioned that the Degeneration system should stiffen the spine and create a normalization of the stress strain curve. And in fact, it might, but it may be causing, it may be inserted in such a way that flexion is induced, or the axis of rotation may be changed, which stresses the disc space more. And regardless, it doesn't appear to be clinically effective. And then if we do a fusion, we achieve exactly what we want. We eliminate the stress strain curve. We have an infinitely steep stress strain line, if you will, and have eliminated the normal stress strain curve and traded it in for no motion, which we know is effective in some cases with mechanical back pain. Now, let's look at axial loading. We're now going to take a load and apply it down onto the Charité disc. It is infinitely stiff in axial loading because it's metal on poly. There's no give. Loads are transferred to adjacent segments and potentially to the facet joints at the same level. The rubber implant or elastomeric implant, again, looks about the same. It compresses, so it has a little bit of a buffer, a little bit of a sponge, a resiliency that a normal disc would have. And similarly, the Degeneration system probably functions biomechanically okay under these circumstances. And of course, if we do a fusion, again, we're infinitely stiff because we have eliminated motion. So I've already alluded to this, adjacent segments versus segment. So if we have this very stiff device in axial loading, it is going to, when an axial load is applied, is going to transfer that load to the discs above and below. And if there's any angular motion with that loading, it's going to potentially transfer load to the facet joints at that level. So this all causes me to pause and to think about how to solve this Rubik's Cube problem. Well, in the cervical spine, we're dealing with a choice after we do an anterior cervical discectomy of no bone, no graft, allograft or a cage, or allograft or a cage with a plate, or a total disc arthroplasty. So we have a lot of choices. So the thought process that went into generating a rationale for doing a total disc arthroplasty was based on the obvious, somewhat intuitive but erroneous notion that preserving motion is going to place less stress at adjacent segments. Now keep in mind, I just outlined why I think it actually increases stress at adjacent segments, particularly with axial loading. The literature that preceded the employment of total disc arthroplasty is relatively clear regarding adjacent segment degeneration and disease. Adjacent segment degeneration is the manifestation of radiographic degenerative changes at a segment adjacent to an index procedure. Disease, adjacent segment disease, is symptomatic degeneration. In other words, there may be neck pain or radiculopathy, etc. So we know that the rate of adjacent segment degeneration, or excuse me, disease is about 3% per year. And I'm going to go over this with regard to literature that existed in the days before, in the era before the widespread use of total disc arthroplasty. Hillebrand from Philadelphia et al. Did several studies with a follow-up of 4.5 years, and they looked at the prevalence of disease, adjacent segment disease, after ACDFs to be in the 9 to 17% range, with an annual incidence of adjacent segment disease following ACDFs of 1.5 to 4% per year. That's, let's just call that 3% per year. Very interesting study out of Minnesota looking at a large number, 846 patients who underwent a laminoforaminotomies. Now, I remember I said there are a variety of motion preservation techniques, including using no implant. So a laminoforaminotomy decompresses the nerve root and preserves motion. They noted that following that operation, there was an annual incidence of adjacent segment disease of 3% per year. Lunsford from et al. From Pittsburgh looked at 253 patients with anterior cervical discectomies with or without fusion. And there was no difference between fusion or no fusion. And the annual incidence of adjacent segment disease was 2.5%, or roughly 3% per year. And then one of the most enlightening studies, I think, is also from the Philadelphia group, where they looked at 409 ACDFs and found the incidence to be 3% per year. And in their multi-level ACDF group, there was a lower incidence of adjacent segment disease than in the single level ACDFs. So I'm not sure what to make of that, other than when there is adjacent segment disease, it usually occurs at C5-6 or C6-7, the most vulnerable disc bases in the cervical spine from a degenerative perspective. So most multi-level operations would involve both of those. And maybe taking out a vulnerable segment can reduce the incidence of adjacent segment disease. But one thing is for certain, it does not appear that the length of the fusion adversely affects the incidence of adjacent segment disease. There is ample literature looking at mechanical, biomechanical, and clinical data that supports that posture is perhaps the most important factor involved with adjacent segment disease. The placement of a spine in a kyphotic posture greatly increases stresses in the adjacent segments, and more than likely results in clinical manifestations of accelerated adjacent segment disease. So here's two patients. This patient has an ACDF and is fused in a slightly kyphotic posture compared to this patient in which the posture is lordotic. Now, I don't know how each of these patients did 10 years down the road. I'm only going to speculate that this patient's adjacent discs are in their normal posture, and this patient's adjacent discs are in a slightly kyphotic posture, and hence the stressors will be much more significant in the patient on the left as opposed to the patient on the right. So this is a disclaimer. I have never implanted a total disc arthroplasty in a living human. But I was involved with the development of a disc that didn't make it to market because of financial issues. It takes a lot of money and a lot of time, and it just didn't happen. But we can tinker with the geometry and materials to reproduce a normal or relatively normal stress strain curve. And this is the disc that we developed. It had a polymer core. It had retaining plates to keep the polymer core from delaminating from the metal end plates. It has rails for acute fixation to the bone and an end cap which allows for expansion of the polymer. So here's the polymer absorbs and releases stresses. The edges of the implant diminish von Mises stresses at the perimeter and results in 10 million cycles. These devices did not delaminate or fail at the polymer metal interface. And then there's this little gap below that plate that I mentioned, which can expand when the stiffness rises. So here's the way the device looks like when it's compressed, when it's expanded, compressed. And so if we study this mechanically, we see that the polymer absorbs and releases stresses and shock of normal motion at low loads. At higher loads, the edges of the plate limit polymer expansion. And at heavy loads, expansion chambers fill under that cap. And voila, we have created what appears to be a relatively normal but artificial stress strain curve. So many of these patients that have had surgery may not have needed surgery. For example, if we're operating on the lumbar spine for mechanical pain, we must make sure they have mechanical pain. That's pain that is deep and agonizing in nature, worsened with loading, and improved with unloading. And so I would encourage us all to amuse the patient, because oftentimes the disease will cure itself. And I have obviously reflected a bias. So I will entertain criticisms or suggestions or argument. But we all know that there have been multiple technologies that have started off with promising preliminary data and early reports were very positive and people got on the bandwagon and demonstrated great clinical results, and it becomes a standard of treatment. This is Scott's parabola, by the way. You can look this article up, and the references down here is in a gynecological journal. But then people start seeing complications and failures, and doubt creeps in. Then there's damaging surveys. Then there's medical legal cases used only in highly special circumstances, falls into disuse, and then very old surgeons like myself amaze their juniors with rollicking stories of the old days. The trouble is with this rise and fall of technology is that under the wake of this curve, under the cross-sectional area represents a lot of destruction, a lot of money lost, a lot of money gained, and potentially a lot of patients harmed. I think we should be very careful and scrutinize technologies that we embrace as we move through our careers. So I thank you very much for thinking through this with me, and I will entertain any questions.
Okay, thank you. Thank you very much, Professor Benzo, for your excellent presentation. So actually, Professor Benzo talked about not only the artificial disc, but talked about almost all the instrumentation of spine, both motion preservation and fixation, based on biomechanics, and really help us to reflect our daily work, what we are doing our daily work. Thank you very much, Professor Benzo. So any questions?
If I could make a comment there. You know, I wrote the book on biomechanics of spine stabilization, and it's sort of disheartening in a way that it is, the principles are not more widely accepted, because failures of surgery are going to be wrong operation period, wrong diagnosis, and execution. And execution of a procedure, particularly in spine, really depends a lot on an understanding, a deep understanding of the mechanical principles involved.
Thank you so much. It was a very, very interesting lecture coming from a giant like you. We had a lot of learning today, and we are really, really excited to get those pearls of wisdom. I would like to invite my co-host, Dr. Liu Gun Seng, if he has any comments.
Thank you, Raja. Thank you, Professor, for a very informative lecture. Professor, I just want to find out from you, based on your experience, because we do experience some arthroplasty that fuse if we wait long enough, and whatever biomechanic that been produced is not working in that sense that what we want. So what do you think that is actually happening? Why those arthroplasty eventually leading to natural fusion? My second question, Prof, do you think that the acceleration of degenerative is due to our habit, our daily habit, because we tend to flex most of the time during dining, reading, and reading phones, such as those activities? Does those activities increase the degenerative process of the neck or the spine? Thank you, Professor.
Sure. First of all, when we insert a total disc arthroplasty, it's usually in a young or middle-aged person. From that point on, the arthroplasty doesn't change necessarily, unless there's failure, and I'll talk about that in a second. But the patient's spine ages. So the arthroplasty doesn't adapt to that. And let's just say the arthroplasty works very effectively at allowing flexion, extension, and lateral bending. And then the patient's adjacent segments naturally degenerate with time as the spine ages. And so the implant doesn't really adapt. Sometimes the natural fusion process occurs regardless of what we do. And it's probably accelerated most with devices in which there's little bone dust left. The Bryant device is notorious for that because it involves milling of bone and leaving of bone dust particles that probably lead to fusion. And so they've recommended non-steroidal anti-inflammatories to try to minimize bone fusion in those patients. I'm not sure how effective that is, but the bottom line is the most important thing I think I said here is that the device doesn't change with time, but the spine does. We get old. And I don't, if I had a disc placed when I was 30 and I'm now 72, who knows? We don't know how that is actually going to pan out. But the salvage procedure is not bad. Like a posterior, for example, if there's spinal stenosis, the patient could undergo a fusion, or a laminectomy and a fusion, or even adjacent segment anterior fusions. But usually the salvage procedure would be a dorsal procedure because you could fuse the facet joints and gain adequate decompression of the spine.
Dr. Ajit R wants to ask one question.
Thanks, Professor Benson, for excellent talk on this very difficult topic. My question is regarding arthroplasty. Usually we do arthroplasty when the joints become less mobile. And to make it more mobile, will it increase the pain? So, many a times, the patient will have a more pain after the arthroplasty. Do you have any comments regarding this, or what are the methods or anything in the selection that can prevent more pain after the arthroplasty?
I have no experience in that. I think the way to avoid that is to not do an arthroplasty. But that's an oversimplification. And I recognize that many of you all do arthroplasties. I am simply here to cause you to think about it. And I'm not saying, and by the way, total disc arthroplasty, hope versus hype. Again, to be determined. I don't know that the jury is out yet. We need more information. We need non-biased information in the literature. Please keep in mind, I showed that Scott's parabola, the curve that goes up. All the studies on the left side of the curve were done by surgeons who were enthusiastic about the new technology. And so when you're studying total disc arthroplasties, and all of the study participants are surgeons that favor arthroplasty. So study design, determination of adjacent segment disease, and indications for salvage operations are made by a person who is very biased. And in the studies that were done early on, patients couldn't have access to the arthroplasty unless they participated in a study. And henceforth, due to the randomization process, only half of the patients would actually get the arthroplasty. And then there's associated with that a loser-winner bias. The patient feels like they hit the jackpot if they got the kyphoplasty, total disc arthroplasty. And those who didn't will feel like they didn't get what they wanted. So there's a lot of problems with the studies that have been out there, and I think we got to carefully scrutinize them.
Right. Thank you very much. May I just ask one question to Professor Benzel? What are your views regarding transfacetal screws? Because many people now, newer philosophies are coming up, especially Professor Atul Goyal is a proponent of this technique, where he believes that the degenerative process begins in the facets, and once you fuse the facets, the degenerative process reverses. So
You're talking about lumbar?
both lumbar and cervical.
Well, I have no experience in cervical. I have done some years and years and years ago, 30 years ago, 25 years ago, did studies on facet lumbar screws, and they're actually, from a biomechanical perspective, almost as stable as pedicle screw fixation. But that's not intuitive, right? And so clinically, they had a rise in use and then a fall. I know that Dr. Goyal is enthusiastic about a lot of things, and he is a very good surgeon. And so, I don't necessarily believe that fusing the facets is the key. I think fusion is the key to success.
Right.
In other words, you don't have to just have a facet fusion. The act of fusing the spine and eliminating motion is where your results are going to come from.
Thank you very much. So it was a very insightful lecture and we had learned a lot. I would like to go back to our chair, Professor Feng Zinjian, for his concluding remarks.
Okay, thank you, Professor Benzo. Thank you all the participants. Actually, we learned more from the presentation and from the discussion. I think it will be very helpful, very useful to our daily work. Okay, thank you again.
Thank you very much. I understand Professor Benzel would be leaving soon because of his busy clinical practice.
I'm going to stay on for just a little bit.
You are most welcome. So continuing our webinars, I'll move on to our chair for the second session, Professor Timo Krings.
Thank you very much, Professor Raja, for the organization of this excellent educational endeavor. Thank you very much, Professor Kato. We will now switch a little bit gears from spine towards stroke. And it's my pleasure to introduce the next speaker, Dr. Aziz Sultan. He's the chief of the Division of Vascular and Endovascular Neurosurgery at the Department of Neurosurgery at Brigham and Women's Hospital. He's the co-director of the Comprehensive Stroke Center at Brigham and Women's, and he's an associate professor at Harvard Medical School in neurosurgery. He completed his training under the mentorship of world-renowned cerebrovascular surgeons, including Professor Harris in Miami and Professor Spetzler at the Barrow Institute. He cross-trained both in open and in endovascular neurosurgery, and this training allowed him to combine the best of two worlds, i.e. utilizing and merging different ideologies and techniques in the evolving field of hybrid cerebrovascular surgery. And coming from these dual backgrounds, he strongly believes in the value of collaboration and the tremendous strides that can be made through cross-pollination of ideas and different disciplines. And he has used these principles to form a world-class team at the Brigham and Women's Hospital. It's actually now a cerebrovascular center that consists not only of neurosurgeons, but neurosurgeons, neuroradiologists, neurologists, and basic scientists. And we believe that this type of collaboration is actually the best way of furthering our field. Rather than competing, he believes in the support of local physicians and hospital systems through direct proctoring or collaborative research projects. And this brings us actually to the talk he will give today, which is entitled Using Stroke and Digital Technologies to Remap Access of Care. I'll just very briefly would like to show you one single slide here that I would like to show to highlight that stroke is actually the ultimate team sports. In acute stroke treatment, we focused up to now way too much on the aspects of acute treatment, i.e. taking the clot out, imaging the clot, finding the right patients. But what is way more important, and I think this is what he will speak today about, is that the transfer to a stroke center, the mapping of how to get a patient to the best potential care is at least as important as the pure act of taking out the clot. In fact, taking out the clot nowadays with all of the devices that we have is relatively simple, but mapping out patient care is where the next big challenge is. And we'll have to understand that stroke management is a chain, and each chain is only as strong as its weakest link. So if the patients don't get to the centers, then we will not be able to give them the care. So he will speak today presumably most about this mapping of patients to get to the access of care. And I'm very happy for him to share his wisdom and his expertise in cerebrovascular disease. And with this, I would like to introduce Professor Assis.
Thank you so much, Professor Kriggs. Thank you, Raja. Thank you, Dr. Keto, for the opportunity to speak here. I appreciate that kind introduction. So I work at one of the best institutions in the country, if not the world. And I have the privilege of being around some of the brightest minds and the biggest hearts. And it's a real honor to work at this institution where Harvey Cushing, the father of neurosurgery, was. But it almost sounds foreign when you say those things about me. What I really am is an Afghan. I come from a beautiful, beautiful country that has faced so many years of war and difficulties. Afghanistan is a beautiful country that was at the crossroads of, and the Silk Road, with so many beautiful cultures went through and mixed, and through this cross-pollination of ideas and cultures developed its own unique way. And if you look at Afghans, they're ones that are blonde and blue-eyed, and from Alexander the Great, or Asian, from the Mongolian. It's a kaleidoscope of phenotypes and cultures and so forth. I was born to these two wonderful human beings in Afghanistan. This is my father and my mother. This is a little bit of a personal talk, but it will get into stroke. My parents were both MD PhDs. My mother was an MD PhD. They were both OBGYNs. That's not the depiction of Afghan women that you see here. The country is now judged, while it's in a difficult position, and sort of reprimanded for the way things are. But how do you judge a country that's been in war for 40 years with superpowers? When I was, my parents in the late 60s went to Moscow to train, and then came back to Afghanistan to serve the people in this women's hospital called Mustarat. In 1978, the Russians invaded. I was 6 years old at the time, and there was a lot of destruction. People from my family disappeared, and we fled the country. This is a picture of my family the day before. We got into back of a pickup truck with 3 other families, and escaped through routes to Pakistan. And then from Pakistan, we went to Germany, where 4 of us lived in this room. I backtracked my path at some point. And in Afghanistan, in Germany, this is 1980, I painted these pictures as a 7, 8-year-old. To me, it wasn't difficulty, it was sort of a game. And my parents maybe gamified everything for me. So it wasn't as difficult as it was for them. We eventually made it to Vincennes, Indiana, and then from Indiana, we were sponsored here by some wonderful, wonderful Americans, the type of Americans that what America stood for and hopefully will continue to stand for, a welcoming place for opportunity. My parents eventually migrated to Washington, D.C. area, where they became janitors at a Holiday Inn and went from MD PhDs to this, but I never ever heard them complain. They were grateful that their children were safe and that we were in a place where there was opportunity. I grew up without a lot of direction and maybe got into trouble a little bit. There weren't any Afghans or any mentors ahead of me. My parents were working multiple jobs, and I found myself in difficult situations, but surrounded by some amazing, amazing, amazing friends. I barely made it to med school, thanks to this man, Skip Williams, a Black man who was the dean of admissions, who decided to take a chance on me. And I went to George Washington University. This is where I actually found mentorship and who I was and a direction in life. And it was with this man, Roberto Harris. And everybody knows Roberto Harris as a icon in neurosurgery and cerebrovascular, a pioneer. But what I know him as is his level of honesty, his level of integrity, his level of commitment to patients and students. And I followed this man every direction that he went. He was an educator, and he spent so much time on us every morning educating us. And he knew all and gave us stories about everybody, like Dr. Benzel and so many icons in our field. He was such a wonderful human being. And he taught me the art of dedication, of spending hundreds of hours a week to really, really perfect our art, to repeat over and over, like a Michael Jordan or one of these elite athletes, to just really dive deep. And above all, he talked about his complications. You know, people in our field sometimes posture and talk about how great they are or how wonderful they can do things and how nobody else is like them. But he, at the peak, talked about how he hurt people. And the reason he did that is that his students wouldn't repeat the same mistakes. And he was completely transparent. And with that, you build trust and you build real understanding and real education. Nobody cares about how great you are, right? They want to really learn something important from you. And I found myself at the brink of a competitive environment between the icons in radiology and the icons in neurosurgery. And I went to Dr. Spetzler and learned more cerebrovascular. And it was a wonderful, wonderful experience to be around this very, very, very special human being, and learned dedication and how to empower people around him and how to build an institute that is greater than the self. And I learned from some of the key people in endovascular surgery, and I was able to somehow meld the two worlds because I was within the first generation of people that could do this, and had a lot of confidence. I came in like a 800-pound gorilla into the room, and this was actually my first case. Subarachnoid hemorrhage, 3 aneurysms on a Sunday with no fellow, and coiled all 3, and I was just unstoppable. And there was an explosion in the field by radiologists and new ideas and new technologies, and I was on the cutting edge of everything, doing all the latest trials, doing all the things. I was just unstoppable. learning techniques from radiologists, using surgical techniques and finding new ways of treating things, whether it was casting aneurysms and new polymers or taking new approaches. As Harrison said, I needed my wings clipped. I was starting to believe my own hype. This poor refugee kid now had everything that he ever dreamed of, the shiny things in life, house on the water and fancy this and fancy that. And when that happens, life humbles you. And sometimes your patients humble you. And this is a young lady, the mother of 3. Husband couldn't come to the hospital because they needed to work to take care of their children. Coiled aneurysms, and if you can see here, that coil pops out, and I try to retrieve it with these original Mercy devices, and I can't. So I take her to the OR, open the vessel, try to take it out. It has a massive hemorrhage, stroke, death, essentially kids, young kids that aren't taken care of. And not only did these types of things really affect me, but there were personal issues in life that had just gotten too big for my own liking, and really thought about how to recenter myself. So I went back to Afghanistan, where I had escaped from in 2007. And when you look from outside, from the airplane, it's dusty and it's dark. And when you get onto the ground, it's beautiful. It's beautiful. It's alive. People are, despite hardships and difficulties, are living. Actually living and enjoying things and trying to survive. It's not what you see, but you see also the difficulties. And this is a county hospital. This is where my brother, Dr. Manawari, worked, who I met by chance. My aunt was high in government. She was also a physician, Minister of Health. She asked me to come and work at a particular hospital. I found my way to the local hospital, and you see how people are just lined, waiting for this. So I went and I found this amazing gentleman who's there with headlights operating. Billions of dollars have been pumped into that country. And the main hospital in the main city, I'm able to raise instruments and give it to them more than it's ever been done before. And that's not an accolade to me. That's what's happening to the resources. Where are they going? Is it going to military, or is it going to the actual needs of the people, right? How can one individual give 4 times the supply to the main hospital that's taking care of patients? And I saw some amazing things. This is the ER. This is a wonderful. This is a resident. He's a resident. He lived in the hospital. Dr. Manawari worked in this hospital for 2 years without payment, and he was presenting cases to us. This is a young boy that came in. He was hit in the head. He came to the ER. They thought there was an issue. The boy's brother had to raise a month's worth of salary, put him in a car, take him across town to a private institution to get a CAT scan, bring him back. On the way back, the boy herniated. We took him to surgery, and I came in to operate as the big professor. And Dr. Manawari kind of pushed me a little bit out of the way and showed me that his residents could operate. And they did an amazing job. And this boy, there wasn't an ICU nurse. That's his brother at his bedside, taking care of him day by day. thank God he did well to the immense talent of these individuals. And that's Dr. Munawari next to me, shoulder to shoulder, had started a residency as Dr. Pirzad has in Aliabad. And these were very, very, very talented individuals. They could operate better than me because I need my fancy microscopes and all these things, but they're able to do these things. And we started to see people that would come. This is a young, beautiful girl with her father that needed a shunt. I wasn't able to help this person. But the father, as you can see, they're happy, loving, caring people. They care about their children as much as you and I do. This depiction of my homeland and the people in the media is not correct. The love that they feel for their own is the same that you feel for your own children. Eventually, I left my home in Miami, and my father, my mentor, Roberto Harris, and came to Brigham, where Nino Kioka recruited me. And here I learned to build. I learned to use the same principles that I had learned as a refugee kid to fit in, or where I had to fit in Germany, and then I had to fit in Pakistan, and then I had, and these difficulties also allow you to understand people and bring in different ideas. And these same principles that my particular path in life led me is the same principles I use to try to assemble teams together, teams that are smarter than me, teams that are better than me, teams that go beyond neurosurgery and art turf, teams that incorporate neurology, radiology, neurosurgery, and we share openly in the principles of Harris. We discuss complications, we develop trust in one another, and we start to mentor people that are around us, young people, and really develop them. I recently finally got an education. I was able to go to school for a couple of years while practicing, and I learned about system dynamics and about not judging the end product, like not judging the tired nurse, or not judging the upset patient, or not judging Afghanistan in its current state, but to understand all the different influences that happen along the way and how you can tweak a system in order to get the product that you want. Now tracking to stroke and what that has to do. My mentor also coined the term brain attack and was one of the first neurosurgeons to talk about stroke and the role of neurosurgeons in stroke. And stroke, as Dr. Krings was saying, has advanced phenomenally and is now becoming a procedure that can be life-saving. This is a patient that is, this doesn't exist in Afghanistan. There's nobody doing thrombectomies, by the way. This is a patient that we enrolled in the Dawn trial in 16 hours out, 16 hours from the time of onset of the symptoms. As you can see, he's aphasic, he's plegic, he's got an MCA occlusion. We're able to use advanced imaging in order to detect stroke and then detect penumbra, area of brain that is at risk and non-functional green compared to the infarct. And we're able to get in quickly without general anesthesia, with patient moving. You see the cutoff over here, and we're able to just take these sort of advanced devices that are improving year over year. And this is a particular stent retriever. Allow me to fast forward a little bit. This is a balloon guide, the catheter going up. This is not the difficult part, as you can see. And we're able to open the vessel. It's 16 hours out. And you can see this is the clot that was causing this man's deficit. This is an hour later in the ICU. this is 2 weeks later in my clinic. He's walking. It's a revolution in our field right now. It's not neurosurgery. It's not radiology. It's not neurology. It's a combination of everything, which can lead to this, right? If you're a neurosurgeon and you're concentrating just on, hey, I'm going to do aneurysms, you don't open yourself up to this type of impact in patients. COVID happened. We became localized to one place, and I have spent 7 years trying to build our thing at Brigham. And during COVID, there was this longing of what can I continue to do? We were doing emergent cases, electives were down, and there was this gaping hole about my brother that I hadn't talked to in a very long time. This is Dr. Manawari back. I visited him a few times. And I started to understand, like Dr. Craig was saying, that endovascular and stroke isn't a procedure. It's a collaboration of groups of people, of different specialties, of different ethnicities, if you will. And that it's a detection of the stroke, the EMS, the patient understanding the family, the EMS, the ER physician, the radiologist, it's all. And if you can take this process and if you can start to really not make it sequential, and that you can start to parallel workflow and you can start to communicate better, and you can use some of these engineering principles of workflow optimization that I had the privilege of learning, that you can really, really, really create a smooth system that really, really provides access and time savings for one of the most critical things. And then we started to map out here in Boston all of the areas that were referring to us, and really, really try to connect the dots and figure out how we can start to collaborate, not only in sort of advertising like, hey, we're here for you, but how to actually align so that patients can actually get to us quicker, or patients that could stay there and get the best. And this is where the hockey puck is going. This is a program that one of our friends developed at Stanford. It's AI detection. It sits on a CAT scan in, say, Cape Cod, and as soon as a ER physician orders a scan and for suspected stroke, it calculates all of that, and within 6 minutes sends it to my phone while I'm at home or whatever. So it skips all of those things. It skips the sequential process of ER physician ordering, CAT scan being done, CAT scan going to a radiologist interpreting, calling the ER physician back, the ER physician calling the access center, calling me, then I say I accept, and so it Uberizes medicine. It just completely collapses the critical time to a very, very short period of time. And imagine if that lived in a scanner for that 16-year-old boy in Afghanistan, right? Who didn't have to drive across town, and then for the scan to be sent to Pakistan for an interpretation, and then didn't have to wait. Maybe he wouldn't have herniated on the way back. Maybe it would have been instant. Maybe it wouldn't have relied or money gouged this poor family so much. Technology, software, right? And in our backyard, now there are companies that, those of you who play video games, you can use an Xbox joystick to control catheters from outside the room. And the technology is advancing so that with 5G, the lag of movement to catheter movement or robotics is very, very minimal, to the point where they can actually operate from San Francisco to New York very easily. imagine if we could potentially do this across countries. Imagine if we could, instead of flying drones that harm people, that we could actually make an impact like this. Imagine that. Imagine if your joystick healed people instead of hurt people. Imagine what type of world that would be. So back to my motherland. I've been very privileged to work with Dr. Key Park and the Harvard Global Initiative and Surgical, and Dr. Adam, who's on this call. And I've been very, very, very privileged to work with some very, very, very special people from Japan, Dr. Kato, Dr. Tarek, Gail Rousseau. The most special to me are Afghans. Dr. Kais, who's ran out of electricity but is on Zoom in this picture because of his dedication. Dr. Pirzad, who's running the program at the main university there. Dr. Munawar, you have known for so many years. Very, 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 very special people, neurosurgeons, doctors, humanitarians who have been working at the most difficult scenarios and doing the best level of surgeries. We started to map out centers. We're in the midst of this in Afghanistan to see how we could, as healthcare professionals, as humanitarians, start to collaborate between these different areas, start to maybe even figure out how technology and some of these things could actually help leapfrog us to a healthcare system that may be ideal. I've seen this in Eastern Europe where the systems are mapped out and people can get access to different places within a very short period of time. And if we could solve this problem for neurosurgery, like if we can actually use the collaborative process and the technologies that are available to current day stroke care, these mapping and connection and access plays, because what's needed in neurosurgery and stroke is to get patients within, otherwise the brain is dead. But these same principles, according to Gail and a number of other people, work for things that are much, much more profound than neurosurgery, right? Whether it's trauma in a country that has the highest level of trauma, whether it's surgical emergencies, or whether it's OBGYN in a country that has the highest infant mortality, where the future is getting completely choked. Imagine if we as healthcare workers started to implement systems that could actually teach politicians how to do things, and that could actually solve problems for the most suffering of people in the world. And if you can solve this problem, I think you can solve any problem. Maybe I'm idealistic. Maybe there's a burning thing inside me about where I'm from. But that's what defines Afghans. We push in the face of challenge, and we try to do good as much as we can in the difficult world that we're in. Thank you so much for allowing me to speak. And thank you so much to my wonderful, wonderful colleagues in Afghanistan, in Pakistan, Dr. Tarek Khan, in India, in Japan, and for all of your support. And I hope to God that we can make this work at some level. Thank you.
Thank you very much, Professor Sultan. This was really an amazing and very humbling talk, very personal and truly touching. We were lucky here in Toronto at the Toronto Western Hospital, together with my colleague, Dr. Pereira, to do the first robotic surgery actually in November 2019. For the time
Can
being,
you still see me?
Yes, I can still see you. Can you see me? Can you hear me?
Yes, we can.
Okay.
Okay, sorry. I was on mute for a second. I apologize.
Okay. So what I was just saying is that we were indeed humbled and touched by your very personal description, and we do believe that the future of medicine is indeed this type of collaboration that you very beautifully described. I also believe that one of the possibilities that we can have now is with the artificial intelligence tools that you briefly commented to indeed increase and select the right patients to come to the centers and to increase patient care, especially in remote areas and in underprivileged areas. And I believe that this is the future of medicine, and we as humans have to work together and begin to live in a different type of mindset that is less a silo mindset, silos of countries, silos of ethnicities, silos of religion, silos of even if you look at our own profession, silos of radiology versus surgery versus neurology, but actually putting into the center of our attention that that made us become physicians, i.e. the patient. And I think that you made a beautiful point to this. I would like to open it to the panels and the attendees, whether there are any questions regarding your talk.
Right. May I call upon Dr. Adam Ammar, who is here? Dr. Adam, can you hear us? Dr. Adam Ammar.
Yes, I can hear you.
Would you like to say something?
Yes, thank you. It was a wonderful talk. Thank you, Dr. Sultan. Every time I listen to your talks, I learn something new, and it's always great to hear. I think the importance of this is really in this talk about teamwork and moving outside of silos, like Dr. Krings mentioned, as well as we can't push anything forward unless we're willing to collaborate with others and willing to look beyond our own perspectives and understand what others go through and how others approach different issues. Especially, being born and raised and trained in the U.S., we talk about Harvey Cushing and all these other American neurosurgeons, but we often forget that there are fathers in neurosurgery throughout the world, in Europe, in Asia, everywhere. Afghanistan has its own colorful history of neurosurgery dating back for a very long time. And very often we look at, especially low and middle income countries, and we think about what are the deficits, and we forget that in a country like Afghanistan, they have 74 neurosurgeons. There's this rich history where they've had entire hospitals dedicated to neurosurgery. They have a lot of capabilities, and it's been damaged by war, and in each country they have their own challenges. And so there's a lot of opportunity there, and this technology that's being developed in other countries can help leapfrog us and a lot of these countries into capacities that took us decades, centuries to achieve. We could achieve it within a much shorter amount of time.
Yeah. Thank you so much for your comments, Adam. I just wanted to reiterate one thing. It's opportunity, right? That's the key. The talent is there. Like, I have personally learned from Dr. Jaweed, who's in Malaysia now. I have personally learned from Dr. Manawari when I went there, and they're very, very, very smart, driven, talented individuals that don't have the same access to things. I'm exactly like them, if not a notch lower, except I've been given these opportunities to imagine if you gave these people the same opportunities that I fell into. it's not talent or history, or and it applies not only to Afghanistan, but the entire world that we may not see in our own silos, as Dr. Krings was saying. There's a lot of special, talented people there. So, yeah.
Thank you very much. I presume that Dr. Javed you are talking is the same here with us.
Yes.
Dr. Javed, are you here? Would you like to say something?
Yeah, thank you very much. Indeed, it was really inspiring talks. I congratulate Dr. Sultans and the panel to involve Afghanistan. Actually, I have been involved with Afghanistan for the past 10 years. And what Dr. Sultan said, my story is almost the same. And I think we love the countries. There's a lot of talent there, but unfortunately, I think all the miseries for the past 4 decades there, it's a little bit unfortunate. So I congratulate Dr. Sultans, and we hope for the countries to one day come, the peace will come, and we can help the country. Thank you, Dr. Sultan, for your highlighting and bring Afghanistan to spotlight. Thank you.
Thank you very much. I think that was a very wonderful session. I would like to go back to our second chair to hear his concluding remarks.
Yes, I think we have to thank Professor Kato and you, Professor Raja, for organizing this, for bringing indeed the world together, and for not only talking the talk, but walking the walk to actually have the World Federation here together to teach and to learn from each other. And as such, we are grateful for the opportunity, for having had the possibility to share this really wonderful session that Dr. Sultan really beautifully presented.
Well, that was it. Thank you very much. I would like to close this officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to sincerely thank both the speakers of today, Professor Edward Benzel and Professor Aziz Sultan, as well as the chairs, Professor Feng Zinjian and Professor Timo Krings, for the time and support for the ACNS webinars. A special thanks to Professor Shubin from China, who has arranged a WeChat broadcast for this webinar in his country. As of now, there are nearly 700 participants who are watching us live in different streaming platforms like WeChat, Zoom, and YouTube. And also, I would like to thank my co-host for today, Dr. Liu Bun Singh, and as well as all the distinguished faculties who have joined us from different parts of the world. I would like to inform the audiences of ACNS webinars that with this webinar, we conclude our anniversary edition of webinars, and we will be back again with our routine webinars from next month onwards. I would like to sincerely thank all the audiences and well-wishers who have supported us throughout this year. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much for joining me.